Good afternoon, everyone, and welcome. My name is Craig Latham, and I'm the Executive Director here at NERI. I want to welcome you to today's webinar, Clinical Assessment of Children with Problematic Sexual Behavior, an Overview, presented by Dr. Jane Silovsky. Before turning this webinar over to Jane, I want to take a moment to tell you about NERI Press. Our mission is to share current research and best practices emerging in our field. For many years, we accomplished that mission only through book sales. But with changes in the last several years in the publishing and technology worlds, we are now disseminating knowledge in several additional ways. Over the last 6 years, NERI Press has also offered online courses, a free monthly newsletter, in-person trainings, and these webinars delivered by our internationally recognized authors and other experts in the field. It's important to us at NERI Press to hear what kinds of information, training, resources, and books you want. So please contact us with your suggestions, questions, and feedback, whether it's positive or negative. Just out of curiosity, how many of you out there have participated in a NERI Press webinar before? Tim, can you launch the poll, please? Okay, great, thank you. Looks like we have a lot of repeat attendees. Welcome to all our friends we haven't met yet as well. I'll talk more about this at the end of the webinar, but I'd like just to make a pitch that if you find these webinars helpful, we hope you'll consider becoming a sponsor of our webinar series. You can think of our webinars like Car Talk on NPR. It's your sponsorship that helps make this series happen and that allows us to offer our webinars for free to the thousands of clinicians and other professionals who have participated in them over the last several years. Please consider becoming a sponsor of this webinar series. Becoming a sponsor guarantees you a seat for every webinar in the entire series. We will register you and 15 staff members from your organization for each webinar, offer you a free gift of 2 NERI Press books, and mention you in all of our publicity about the webinar series and at each webinar. Now, before we get started with Jane's presentation, there are a few more things I'd like to mention. First, as with all workshops, I want to let you know that there are learning objectives. In this workshop, participants will learn about the use of clinical assessment for decision-making for youth when there are concerns about sexual behavior, learn about topic areas important to address in clinical assessment, and learn about developmentally appropriate considerations when conducting clinical assessments with children when there are concerns about their sexual behavior. Second, I want to let you know that YouTube recording from this webinar will be posted on the NERI Press website around February 21st. Slides are currently ready to download from the NERI Press webinars page at www.neripress.org/webinars if you'd like to follow along. And as Tim mentioned at the beginning of the webinar, you can also download slides right here from your control panel on the lower right-hand side of your screen. Third, when the workshop is over, please answer the short survey at the end. We would love to have your feedback. And finally, in about a week, you'll receive a follow-up email with the link to the recordings and to a certificate of attendance that you can download. And now it is my great pleasure to introduce our speaker. Dr. Jane Silovsky is a clinical and child psychologist. She received her doctorate in clinical psychology from the University of Alabama. Currently, she is a professor in the Department of Pediatrics at the University of Oklahoma Health Sciences Center, where she is also the Associate Director of the Center on Child Abuse and Neglect. Since 1997, Dr. Silovsky has been the director of the Children with Problematic Sexual Behavior Program, an assessment, treatment, and research program for preschool and school-age children with problematic sexual behavior. Dr. Silovsky is also the director of the National Center on the Sexual Behavior of Youth, which provides training and technical assistance to communities addressing problematic sexual behavior of youth, the child victims, and the caregivers. Her research is in problematic sexual behavior of youth and treatment outcomes and program evaluations of services for children affected by child maltreatment. Welcome, Jane.
Can you hear me okay?
Yes, please go ahead.
Welcome, everybody. It's good to be here today, and I thank NERI Press for inviting myself and my team members to provide some information in terms of children with problematic sexual behavior and what's involved in terms of that clinical assessment piece. All right. So can you see my screen?
There you go. Now we got it.
Okay, great. Wonderful. That's what I was waiting for is this little panel to show me what to do. All right. I wanted to say hi to everybody. And so you can see me, but I'm going to go ahead and show the PowerPoint for the presentation, and I'll come back out as a visual at the end for the Q&A piece. All right, so in talking about children with problematic sexual behavior and what to assess, really a number of questions come up in determining what to focus on and how to approach this assessment. One of the questions, I think, it sounds very basic, but so critical, and that is, what is sexual development in children? I don't know how many of you are parents, but I am. I have 2 kids, 2 girls, and one is actually a teenager. And I've reflected a lot about what sexual development is, and sometimes I wish sexual development may be better if it didn't start till they were 22 or something. But it's important to realize sexual development is throughout childhood. It doesn't even start at puberty. It starts when they're babies. And so in order to figure out and really assess problematic sexual behavior, we have to have a solid foundation in what is typical. And so we're going to spend some time talking about that, and then talking about how that then becomes something that is of concern, and when we should be concerned about it, and then more importantly, maybe when does it rise to the level of needing treatment? What are the factors that need to be considered as you're thinking about treatment, and how does that guide your treatment planning? And problematic sexual behavior is an area of behavioral health that tends to impact others, the safety of other children that may be impacted by that behavior, the impact on the caregivers involved, the teachers. And so needing to really think about for this area that may be unique to other behavioral health areas like depression or anxiety, is thinking broadly about safety of all the kids involved and what needs to be in place moving forward. So I'm going to start with talking about typical sexual behavior and sexual development. It really is part of all children's development, and it's helpful to think about how this is occurring within all the other areas of development. It's not something aside or somehow unique or occurring on a solo area. It really makes sense given what we know about everything else in the child's development, their cognitive development, their social development, their moral development. How are they learning about the world? What are the ways that they're learning? How are they learning about language? And knowing that information helps you be able to determine if what you're seeing is part of that typical development. So kids' sexual behavior and sexual knowledge should make sense given where they are in their development if it is a typical behavior. It's often triggered by curiosity. Kids are trying to learn about the world, learn how things work, learn how things come apart, put together, learning about sameness and differences. And that curiosity happens about bodies and relationships and friendships. And so they're curious about how boys and girls are different and how they're different than adults. And as they get older, they're curious about intimacy and relationship and all of those kinds of things because they're trying to learn about the world. And they're using language around everything in the world, including their bodies and relationships and so forth. They'll hear things in songs, on the TV, from peers, they'll mimic it, they'll repeat it, they'll mimic behavior, and being able to trying to determine where they're learning that, what their understanding of it, can help you figure out, is this something that makes sense given where they are in their development. Another key component of it being a typical behavior is that everyone involved is agreeing to the behavior. Young children cannot consent. They don't have the capacity to think about the long-term implications for a legal consent. But when it's typical sexual behavior, all the kids should have agreed to it. There's no dissent. There's no strong feelings of anxiety or anger. Any of those things would be red flags that this is really falling in the lines of something more concerning. There is a purpose to sexual development, and I joked earlier that maybe it would be better if they started when they're 20, but the reality, wouldn't the world be pretty awkward if sexual development didn't start until we were all 20? We would have no idea how to share and communicate and interact with each other. So the fact that it starts early on and occurs throughout their childhood helps them test things out, develop healthy friendships and relationships, learn how to communicate, learn about boundaries and healthy nurturing, and all of that, those pieces occur across that whole period of development. And when you're thinking about that process, you can think about factors that would make that more difficult and some that would help that whole process. And that's part of what we're going to talk about today. So we've talked about typical development. It's helpful to have some guidelines when you're assessing problematic sexual behavior to see what you're learning. Would it fall into something that would be considered more concerning or problematic? Some of these are more obvious than others. One area is on this right column is the area of harm. When sexual behaviors are harmful to another person, there's force, intimidation, coercion involved, painful experiences, intrusive behaviors. If kids are feeling fear or anxiety, those all would be problematic and potentially harmful sexual behaviors. No culture in the world are those kinds of characteristics part of normal sexual development. So those are all big red flags that this is something that's beyond normal development and in need of treatment. Other areas you'll need more details to try to determine where it may fall on that continuum. A common question we have is when kids are having sexual behaviors with each other, is there some kind of magical age difference that would indicate this is a problem versus this is typical? Indeed, some states have in laws that if there's an age difference of 3 or sometimes 5 years, that would then be an illegal sexual behavior. I encourage you to examine the likelihood that these children who are involved would otherwise be playing together in a healthy way. Are these kids of similar developmental abilities, sizes, not just chronological age, such that their playing together would make sense, and a curiosity-driven behavior around that may be more typical. When, however, there's a kid that has more power, capability, size, etc., than the other child or children involved, that's when you're going to become more concerned. Certainly, it is not considered normal when it's a 12-year-old and a young child, like a 3 or 4-year-old. But if there are two 10-year-olds and one is functioning like a typical 10-year-old, but one is functioning more like a 6-year-old, then there would be more concern. You're looking at the duration of the behaviors, how preoccupying it is, how does it interfere with their otherwise typical development, and being able to engage in other kinds of play and interactions with kids. Another piece to consider is how frequent it is and how much is it interfering and excluding the kinds of activities they might be involved in otherwise, and does it respond to parent, teacher, other adult intervention? Kids break rules. They are not born learning all the rules of the world and understanding societal process. They often will test rules, try things out, and how they learn what rules to follow is that they get guidance and supervision and feedback. So most kids, when receiving feedback about appropriate boundaries and behaviors, they can then follow those rules. If they're not responding to that feedback, then you're going to be more concerned that this is a problematic sexual behavior. So there are multiple potential goals when you're referred a child for a clinical assessment and you're looking at problematic sexual behavior. And one of the basics is this a problem? Is this a sexual behavior that's beyond what would be typical? And we encourage you to take time to interview the caregiver, and depending on the age of the child, gathering information from the child in terms of details about the behavior. What happened beforehand, and we'll talk a little bit more about this later in the webinar. There is a measure that is useful. It's developed by Bill Friedrich. It's published by PAR, called the Child Sexual Behavior Inventory. It's the only normed measure of child sexual behavior. It's relatively easy to administer, and it would allow you to compare this child's caregiver's report of the child's sexual behavior to other boys or girls their age, and their norms from ages 2 to 12 years of age. This can be particularly useful in looking at that frequency question. So this 5-year-old sexual behavior is occurring. Is it more than other 5-year-old girls or boys their age? As you're gathering that information and you're determining, is this a problematic sexual behavior, begin looking at what treatments might be helpful in your decision making. One thing to be aware of is problematic sexual behavior in itself is not a diagnosis. And in my opinion, it shouldn't be, because it may be related to a variety of conditions, or it may be the primary and only issue for that particular child and family. So gathering information in terms of the behavior, sexual behavior itself, but also how is that child functioning overall at home, in the community, in school, and are there concerns about other conditions? Has the child experienced trauma or other kinds of scary situations that they have traumatic symptoms, such as post-traumatic stress disorder? Do they have other behavior problems, oppositional behaviors, impulsive behaviors, and how that might be addressing and impacting their current behavior? And as you're getting this information, wanting to hear what are protective factors, what are some supports in the homeschooling community to help this child get better on track? And what are some concerns in terms of safety that an immediate needs to be addressed in terms of things like bedtime or bath time or time with children that currently isn't well supervised? So your goal would be to gather enough information to determine what kind of safety plan is needed and begin that implementation of the safety plan. So is there a certain profile or condition or way of thinking about this particular child would be the type of child with problematic sexual behavior versus not? Well, the reality is that a wide range of children have problematic sexual behavior, and that's true that boys and girls have problematic sexual behavior. Often, if you looked at the adult or even adolescent literature, it's predominantly males who have illegal or problematic sexual behavior in those age ranges. However, when you're looking at children 12 and under, both boys and girls. And in fact, in our preschool program, we have found more girls than boys presenting with problematic sexual behavior 6 and under. We see problematic sexual behavior in children as young as 3. As I mentioned, we have a program for kids 3 to 6, as well as one for 7 to 12 years old. There's not a distinct profile for them, and it's important to think broadly about protective factors and risk factors and not exclusively consider sexual abuse. I'd say when this field first started, there was a lot of assumptions that all of these children must have been sexually abused if they have problematic sexual behavior. Indeed, some of Bill Friedrich's early research was try to determine if you can see if a child has been sexually abused by that sexual behavior. His research emphasizes the need to look at these things scientifically, because what he found was, no, you can't, that there are youth with problematic sexual behavior with no sexual abuse history, and there's certainly many children who've been sexually abused with no problematic sexual behavior. And so rather than thinking about that one continuum, it's important to step back and look at a variety of risk and protective factors. First, let's talk about the sexual behavior itself. I mentioned the importance of gathering information from the caregiver and perhaps other people who've been involved that may have information that would be useful to determine the characteristics and specifics of that sexual behavior. When you go back to that chart of those characteristics of problematic, that can help guide you in terms of thinking about what kinds of questions to ask. What types of behaviors are being displayed by the child? Who are they demonstrating with? What is the context of those situations? What was happening before? What adults were watching, if any? Are there any kinds of things that may have triggered or influenced the impact either immediately or previously? Exposure to sexualized materials, perhaps they had been sexually abused, exposure to information, any kinds of things that may have impacted it starting on, a child asking about playing house or those playing doctor. In thinking about the behavior itself, asking open-ended questions in terms of what happened, where they may have learned about it, what kinds of behaviors, was there any force, coercion, was there anything that was done to influence getting the children involved, and then gathering information from those who may have responded to, witnessed the situation, or after they determined it, reacted to it, what kinds of consequences were put in place, what kinds of activities were done that may have increased or decreased the behavior, and how did that child respond to those consequences. In your assessment, in addition to gathering those details about the problematic sexual behavior, it's needed to step back and look at what are the other types of potential contributing factors. I mentioned that sexual abuse is a risk factor, but not the only factor that leads to problematic sexual behavior. The research that has been done indicate there are some kinds and types and situations around sexual abuse that are more risky. When sexual abuse happens at a very young age during preschool, particularly if it occurs with multiple perpetrators, more intimidating kinds of situations, that would be related to an increase in the likelihood of problematic sexual behavior. Sexual abuse is less likely to lead to problematic sexual behavior as kids get older, although it could be a risk factor and a consideration in terms of what they've been exposed to. Not only sexual abuse, but also exposed to information about sex, pornography, music lyrics, other kinds of things that may have led to leading to some types of sexual behavior inquiry about it. Interestingly, what the research is demonstrating as an important coercive contributing factor is models of coercion. So we've known for a long time that factors such as physical abuse, experiencing domestic violence, witnessing domestic violence, having violence in the community is related to a broad range of disruptive behaviors. And the research is now accumulating that it's also related to the development of problematic sexual behavior. So witnessing violence, witnessing not managing impulses and controls well, having a desire and going after it rather than communicating well about thoughts and feelings, these types of models can impact the development of problematic sexual behaviors. Further, youth can have vulnerabilities that impact these situations in developing problematic sexual behavior. So healthy coping can occur very often when kids are able to get social support and reinforcement to think about even scary, tough situations in a way that's adaptive. If you have vulnerabilities that would make that different, you're also more vulnerable to maladaptive coping and problematic sexual behavior. So things like a learning disability or language disabilities. Also behaviors like attention deficit disorder or oppositional defiant disorder, where you're more likely to not moderate your feelings, but instead act impulsively on situations. Kids learn how to follow rules by the messages and supports and guidance of those around them. So family adversity is important to consider as a risk factor because that may limit those caregivers' ability to support their child. So caregivers who are depressed, maybe abusing substances, are not otherwise available for their children, perhaps for their own trauma history, or because they're working 3 or 4 jobs, these kinds of situations that hinder a caregiver's ability to support and guide their child can then be a risk factor for the development of problematic sexual behavior. And now in our emerging technology world, we have to consider the impact of technology. And this has really exploded, particularly perhaps in the last 5 years. And research has not been able to keep up to know what is the impact of technology on our kids' knowledge and behaviors. We do know that kids have been exposed to and have been curious about bodies and have done things like looked at Playboy or pictures of naked bodies and those types of things. And that's been part of typical growing up. But now, because of technology, they are being potentially exposed to a lot more serious kinds of behaviors, videos, not just still pictures, and coercive sexual behaviors. So at a young child, using technology, even for good purposes, may inadvertently get exposed to these kinds of sexual images. And what we need to learn more about is how that then impacts their behavior. Those kids with more of those vulnerabilities that I mentioned in the earlier slide may have a harder time understanding, managing, and addressing those kinds of exposures. And so we need to be aware as caregivers on how we can monitor and manage so that kids are not inadvertently exposed to things that could be potentially harmful and may lead to more serious behaviors.
Jane, this is Elisa. I just wanted to interrupt really quickly. People are writing and asking if you can put the slides into presentation mode so they're bigger on their screens.
It is on presentation mode.
Not what we can see.
I wonder if it's not showing the right screen. Does that help?
Oh, there you go. Perfect. Thank you very much.
Yeah, I am so sorry it was showing the wrong screen.
Oh, it's quite all right. Thank you very much.
All right. I'm glad you interrupted because that's important to be able to see the whole thing.
Yes.
So looking, I mentioned before, those co-occurring concerns. So when you're thinking about treatment planning, What else is going on? Because that might influence then how you respond. So if this is a child that has a pattern of disruptive behavior disorders, ADHD, oppositional defiant disorder, and problematic sexual behavior, when you're thinking about treatment planning, you're wanting to think about addressing this wide range of behavior problems. And there's a couple options in terms of what might be the priority in terms of that treatment. Those kids that have experienced trauma, being able to really assess their reaction to that. Are they experiencing post-traumatic stress disorder? Are they having re-experiencing symptoms from their trauma that's leading to these problematic sexual behaviors? How is that trauma impacting their understanding of the world and on their behavior? Further, again, language and learning problems can impact how they cope with trauma and other kinds of exposure. So how can you support more adaptive, healthy coping given what you know in terms of their current development and preferred modes for learning? As you're assessing these risk factors, co-occurring issues, also be sure to assess protective factors. Those kinds of messages and supports in their life that will help them be able to make good decisions and develop a healthy pattern of relationships. And in fact, I'll talk a little bit later about the aspects of evidence-based treatments, and what I have listed here are really those core characteristics of what you're trying to build with that family in treatment. So being able to have healthy boundaries modeled in the home and in the community and supported with that child. Are they able to be protected from any future harm and trauma? One of the things we found in the program that future traumas or triggers of trauma can trigger problematic sexual behavior. So helping that home environment be able to protect them from future harm is key. Parental supervision and guidance and being able to support, catch them being good, guide that, being able to prevent making poor decisions and implement good decision making, and have open communication about feelings and thoughts and support healthy coping skills. A clear factor related to good outcomes is having healthy peer relationships with kids who are doing well. So part of what you want to look at is, do they have friendships? What are, do they have at least one person that can provide support and guidance, who can model healthy behaviors with them? And do they have aspects in their own growing up that they can experience success and be skilled at? There are some considerations in terms of development as you are getting information about their sexual behaviors, problematic behaviors, co-occurring issues, and risk and protective factors. One, as I mentioned, is sexual development and where they are in terms of their sexual development as they're getting older, where they are perhaps on puberty, what stage are they on, how their sexual development has been addressed and nurtured in the home, or been reacted to in terms of their caregivers. Another aspect specifically around problematic sexual behavior that often comes up is this belief that if the child does not acknowledge that they have problematic sexual behavior, that this somehow is a sign of pathology and severe risk, and that they're perhaps in, quote, denial. Well, it's important again to look at their development and what should you expect in terms of being able to admit wrongdoings and talk about those things. What we know about early childhood is that kids often are hesitant to admit they broke a rule or they did something wrong for reasons such as they don't want to get in trouble. And those types of behaviors are not an indication of psychopathology, but instead of an indication of where they are in terms of their development and their understanding of the strength of being able to recognize when you've done something wrong and talk about it. So being able to understand where they are given their age in acknowledging misbehavior overall, their understanding of how people are going to react to this behavior helps put into context their hesitation to talk about problematic sexual behavior that they've demonstrated. And similarly, in terms of empathy, people have been concerned that they're not understanding their impact on others, when it may be very normal for where they are in their moral development. So as you're gathering this information, you'll be considering then what would be targets of treatment, problematic sexual behavior, other behavior problems, anxiety, trauma symptoms, other areas of development. What's the greatest severity? What's the greatest concern? Who will be involved? And for all of these treatments, you need active involvement of the caregivers, and what types of treatment might be most effective. What we know about evidence-based treatments for problematic sexual behavior is that caregiver involvement is critical for the outcomes. So caregiver directly and actively involved, learning about supervision, parenting skills that increase good behavior, respond to and correct misbehavior, be able to communicate developmentally appropriately about sexual topics, sex education, teach rules about sexual behavior and boundaries, and provide a context for preventing abuse are the key factors in terms of the caregiver involvement. We've done a meta-analysis, and behavior parent training combined with these specific factors were related to the best outcomes. You want it to be skill-based, teach the kids decision-making, and use a cognitive behavioral approach. In terms of safety planning, you're going to be looking at how well the child is responding to supervision. If an adult is in place and watching them, are they able to follow the rules? Are the behaviors manageable by those caregivers? Do the caregivers have the capacity to provide this close supervision that's needed? And who are the other children that are involved in the home, in the community, in school? What are their vulnerability and risk factors? So you would take those into account into implementing specific rules about the behavior, what to do, what not to, what level of supervision is needed, and remembering that kids are malleable, so you're wanting to reassess this over time. I encourage you to know your specific state laws about reporting child abuse and neglect, because there may be situations in this assessment that a report of suspected child abuse might need to be made. Often it's related to the child discloses experiences of physical abuse, sexual abuse, neglect, or if through the assessment it is clear that there were caregivers involved who failed to protect and supervise and provide guidance in a manner that would be considered child neglect. So as you're thinking about the clinical assessment, remember these are children, and begin as a context of healthy, normal child development. If you've had a lot of training in adults with illegal sexual behavior, please leave that training outside the door when you're thinking about kids, because most of that really isn't applicable when you're looking at kids with problematic sexual behavior. You're wanting to do an individualized assessment of the children and the caregivers' risk and protective factors to determine a treatment plan that would make sense given those assessment pieces. And remembering again that children are malleable. So when you write a report or you summarize this assessment, being clear this is their functioning now in the context of their well-being in the present moment, and that is likely to change, particularly with treatment and improvement, so that those assessment results don't stay with them over time and fail to account for progress that they have made. One of your handouts provides a variety of resources and how to access them. We have a website on NCSBY that provides a lot of details, including sample safety plans and information for caregivers. In our collaboration with the National Children's Alliance, we've developed a series of fact sheets and a video training series. And then we have booklets called Taking Action for caregivers to address when they have children with problematic sexual behavior. ATSA has a task force report that summarizes assessment and treatment and policy around these youth. This was the first of a series of 3 on problematic sexual behavior, and I was just really giving you that big picture overview. Next, in March, Dr. Erin Taylor will be covering assessment of problematic sexual behavior in children in more detail in the context of that interviews and information you'll be gathering in assessing those problematic behaviors. And then in April 10th, Shell Millington and Amanda Minton will discuss more that clinical decision-making piece of the problematic sexual behavior, trauma and trauma symptoms, other behavior problems, other concerns, and trying to determine what treatment might be best. And just acknowledging, I do get funding from OJJDP, but I'm speaking for me and not for them, so I'm required to do that acknowledgement.
Thank you, Jane. That was incredibly helpful and useful. And I would invite the audience now to submit their questions. We have several already lined up for you, so I'll start by going right ahead. One of the questions is, what is the age range you would consider appropriate for this developmental style of assessment as opposed to the more actuarial approach that seems to be common in the adult world?
You know, that's an excellent question. As far as a clinical assessment, we recommend that a clinical assessment approach be put in place for children. Well, I'll speak for children 12 and under is really essential. That looking at it as a risk assessment with actuarial or other risk assessment tools is concerning in multiple levels. One, in terms of there's no evidence to demonstrate that those types of risk assessments are applicable or effective for children. In addition, those are suggesting that these kids are at high risk for illegal behaviors and need to be closely monitored. When the treatment outcomes suggest that with appropriate outpatient treatment, recidivism is quite low, and being able to approach them as children first that have clinical needs and doing a clinical assessment that help guides that treatment planning fits better for them. In terms of adolescents, there is a movement actually to move out of risk assessment and looking at more of a clinical approach in assessing them. But I don't really want to go into detail in terms of adolescents because I think that's out of the focus of this particular webinar.
Great, thank you. If I can just make one brief foray out of the focus. Again, several people asked if you are aware of an equivalent of the Child Sexual Behavior Inventory for adolescents?
No, there is not one that one other thing I'll mention is Brian Allen and Lucy Berliner, David Coco, and I are in the process of developing an updated measure of children's sexual behaviors. Bill Friedrich's measure is excellent. It's a little out of date at this point because there are no items in terms of technology. There are actually no items in the published measure on aggressive coercive behaviors. So we are working on developing a measure that will have more up-to-date norms.
Great. Speaking of norms, one of the participants asked if the norms for the CSBI need to be updated in light of the changes in technology since they were created.
Great question. Absolutely. I do believe that we need to get a better sense in terms of the impact of exposure to materials, pictures, videos that kids are having, and how does that impact their behavior, their knowledge, and their development. So not only updating the norms, but doing additional research. The challenge is it is a topic that's very difficult to research, because if you think about it, parents will have to feel trust with a researcher to talk to their children about sexual behavior and knowledge. So it is a difficult area of research, but one that's really needed.
That's great. Do you have any suggestions for people who are doing treatment planning with children around their access to technology? How many hours, how many devices, what content?
So what I would recommend, there is a number of resources in terms of helping support parent controls and communication around technology. I don't know if some of these may be on the NERI website too, and Craig, you can share that. There are website links on our NCSBY website too. The challenge is that technology is ever changing, and kids are better at it than the caregivers. So in general, reducing exposure to technology that's unsupervised, being able to know what they're doing, not only monitor, but interact with them on that. One example is one of the things we do in our treatment program is have the caregivers watch and record everything they see on technology, whether it's games or movies or anything, for a week, and come back and share what they've learned and how much exposure to sexualized and illegal and aggressive behaviors the kids are having on that technology. And it's interesting, every time caregivers come back and share, not being aware of things that their kid are seeing. And so games like Grand Theft Auto, not realizing what Grand Theft Auto is all about till they sat there with their child and watched it. Well, I'd recommend in general that caregivers know that they are with them when they are on the computer or TV or movies and seeing what they're seeing, being able to talk with them about it. And if it is inappropriate, turning the channel, taking it off, and talking about why, and having open communications in terms of healthy decisions that they're seeing and inappropriate things they're seeing and how they would manage it.
That's great. Another question from our participants. You outlined a very clearly developmental clinical approach to assessment. It's much like one would do in a child guidance center for a child presenting with any kind of problem. Yep. And this participant wonders if there are any resources out for planning treatment for children with significant individual vulnerabilities like fetal alcohol syndrome or developmental delays. How would that affect your assessment, and what resources might you use?
And that's a wonderful question, and it comes up frequently. And I would agree first to say is think clinical assessment, and that this is a behavior problem that can be part of it. I think that reduces clinicians' anxiety about being able to address this. Indeed, it is important to think about children's development, the impact of exposure to alcohol or drugs, and developmental functioning overall. There are resources specific in terms of supporting children with developmental disabilities in sex education, in healthy boundaries, and in communicating in terms of that piece, and being able to also work with the caregivers on how to understand their child's development and support that. So something that's been found clinically and in the literature is that caregivers of children with developmental disabilities sometimes have difficulty seeing their children as sexual beings, even in their late teens or even early 20s. So being able to see as they're going through puberty that indeed they are being impacted by that, and how to have a dialogue, open communication that's developmentally appropriate throughout that period to help support the caregiver and the child as the child develops more healthy relationships and decision making. A lot of times simplifying, use a lot of behavioral and visual supports are useful in that process.
Thank you. Another question is, you've done a very nice job of laying out the notion of a clinical assessment and the lack of empirical support for actuarial tools to assess risk in this age range. There are nevertheless other tools that one could use to assess depression or exposure to trauma or other things. Do you have any favorites you'd like to suggest to people for assessing clinical dimensions that you've outlined?
I like to have one of the solid broadband measures. So the child behavior checklists or the BASC are nice because they assess a broad range of behavioral and emotional symptoms, have solid gender and age norms. The BASC is nice because it also addresses protective factors, social skills, those types of things. So it's nice to have that broad piece to see where they are in functioning early on and what more detailed questions or assessment might be needed. Now, neither of those are measures of trauma and post-traumatic stress disorder. There's a number of different measures that might be useful. If you prefer to use the trauma symptom checklist for children or trauma symptom checklist for young children, those are good measures that also have norms and also ask about a broad range of behaviors. There are also measures, the CATS, the UCLA, that look specifically at PTSD and their symptoms. And then other areas, it really depends on what the child is presenting with. For our younger kids, sometimes what comes up is separation anxiety. And rather than a measure, what I've typically done is more of a clinical interview around the separation anxiety symptoms to determine how severe and how much that's impacting their functioning.
Mm-hmm. One of our participants asked about the BASC inventory, which is not familiar to everybody. Can you just explain what the acronym is and where people might be able to find it?
And I always mess it up a little bit. I think it's the Behavioral Assessment Schedule for Children.
That's it.
All right.
And it's very common in schools, so a lot of the children we assess may already have it done. It's very common in children who have individualized education plans. So it's a checklist that there's a form for the parent, form for the teachers, and one for the child to fill out. And it's divided into a number of factors that are pretty useful. That's great.
Yeah, thank you. And the nice thing about that compared to the CBCL, you can go down as young as 8 for the child to fill it out, where the CBCL, the lowest age is 11.
Do you ever use any personality inventories in your assessments?
I haven't found them useful for this age range.
Great. Okay. And you spend time talking to the family as well as the child when you do an assessment, just like a clinical assessment for other kinds of behavior problems?
Yeah, yes, we do. And I'm probably getting much of the information from the caregiver. We do our assessments in teams, so one's with the child and one with the caregiver. If you're by yourself, I really would encourage you to start with the caregiver to get the history, to get the context, to get the information before meeting with the child. And this is a situation where you want to be a model of healthy, well, you always want to do this, but it's probably more of a concern when you have a kid with problematic sexual behavior, to model the healthy boundaries from the beginning. So you are essentially a stranger to this child, and you're going to be potentially, if they're school age, asking them about their behavior, including sexual behavior. So having time with the child and the caregiver, talking about why they're there, what are the kinds of things you're going to be addressing in the assessment, allowing the opportunity for the caregiver and the child to ask questions, and give permission that when we talk, your mom, dad knows that we're going to be asking about these kinds of things, and you let me know your comfort level in terms of talking about this too. That's modeling healthy boundaries in terms of relationships for that child. And some of our children haven't had that modeled for them, and so that helps them get on a good path in terms of those pieces.
Great. And our last question that we have time for today is, you mentioned a couple of indicators that were thought to be key indicators of risk in everybody who had problematic sexual behavior, including denial and empathy or lack thereof. And you mentioned that a developmental context is important to think about those things. Could you say a little bit more about that and the role that development plays in your thinking about any aspect of the child's sexual behavior?
I'm glad you brought that up, Craig, because I want to make sure what I said doesn't get misinterpreted. I don't find, and our clinical work has not supported that, quote, denial is a big risk factor for these children overall. In fact, it's not uncommon for kids to come in and not be able to share details about what happened, and that characteristic is unrelated to their long-term outcomes. It's very, as I said earlier, developmentally appropriate for a 7-year-old to not remember details and not want to talk about some misbehavior. What you do want to look at, though, in terms of that is the severity of the behavior and the level of shame a child may be having in terms of that. So if you know the problematic sexual behavior was severe, that there are impacts to other children in terms of victims, and this child appears to feel shame in terms of it, but denies in that they will not talk about it, that would be more concerning to me, and wanting to help them understand that they are someone capable of making good decisions in the future and be able to directly address that level of shame they might be experiencing.
Thank you so much. This has been an incredibly productive webinar. And I think if we all take away the notion that they are children first and not many adults, we'll be all the better for it. Thank you again for sharing your expertise with us. And we have a little wrap-up business to do right now. We are offering limited CE credits for our webinars. Paid CE credits will be available for psychologists and social workers for all webinars in our 2017-2018 season. For details about how to obtain CE credits, please visit www.nuripress.org/webinars and read through our new CE process. If you still have questions after that, you can email Kristen at klobish@nuri.com. And I think her email is on the bottom of that slide. Yes, it is. I'd like to let you know that we also publish a free monthly newsletter that I mentioned earlier, in which we discuss a new or controversial journal article or research paper and examine its implications for clinicians in the field. You are automatically signed up for this resource, and we hope you find it useful. Please consider becoming a sponsor for our 2017-2018 webinar series. We are thrilled to be presenting a brand new slate of webinars this year, driven by the feedback that you, our audience, have provided about which topics would be most useful to you. When you sign up to be a sponsor, as our thanks to you, we'll send you 2 of Nuri Press's popular titles, Current Applications and Current Perspectives, or 2 new books if you've already received those, and you're guaranteed a seat in each webinar in the 2017-2018 year. And if you sign up as an organization, your organization is guaranteed 15 seats. We will also do your monthly registration for you. We will publicize your name or organization on our website, in our publicity, and on each webinar. Sponsorship is $98 for individuals and $250 for organizations. If you are interested in being a sponsor, please contact us directly at info@nuripress.org or call us. And our next slide shows our sponsors. Thank you to all of our sponsors. You can see them here on the screen. They are organizations, agencies, and individuals. We would like to be able to hold these we wouldn't be able to hold these webinars without their support. Finally, if you like this webinar, you can see previous webinars on our website at www.nuripress.org and on Nuri Press's YouTube channel. It is possible to pay for CE credits for all past recorded seminars. Thank you finally to Jane for such a great webinar. We appreciate her sharing her time and her expertise with us. And a huge thank you to all of you for attending. I'd like to say again how much we welcome your feedback, so please be sure to complete your evaluation form when you close out the webinar. Thank you and good afternoon.
Thanks, everybody.